It's so great to be back again. It seems like we just did our cardiovascular talk on health and wellness a couple months ago. So I'm really excited to be back. This is kind of our second segment into cardiovascular health. And as we promised, tonight we're going to talk about our pharmacological review in cardiovascular disease. My partner, Jonathan, was going to join us tonight, but he sustained a pretty severe back injury. So he is home tonight recuperating, but he sends his best. I see some of our patients are on our call tonight. So thank you all for being here. So tonight we're going to start out with, let's see if I can get this thing moving. There we go. So I don't have any disclosures tonight. All right, so tonight we're going to start out in talking about what is MACE. And we talked a little bit about this in our prior conversations, but all of these medications that we're going to talk about tonight are prescribers. So whether you're a cardiologist or you're an internal medicine physician or primary care doctor, our goal when we talk about pharmacological management is really reducing or preventing what we call our major adverse cardiovascular events. And in our past presentations, we've talked about lifestyle modifications and we've talked a little bit about procedures. But tonight we're going to talk about those medications that are out there that we talk about. And really the goal is to reduce non-fatal myocardial infarctions or heart attacks, non-fatal strokes, or cardiovascular death. So that's really the goal of the medications that are out on the market now. And these are prescriptive medications because, as we all know, there are a lot of over-the-counter medications that also many of us take that also help and assist this. But these are primarily prescriptive medications that we're going to be talking about tonight. All right. The first medication groups that I'm going to talk about are some common medications that and they're very old medications that we often prescribe. But I want to caution everybody about these medications as we continue with the conversation and remind the audience that no recipe or guideline fits the same patient. So what you're going to find during the conversation is that many of you are on some of these or some of these or all of these medications, but the dosages and the combinations of the medications, what work for you may not work for your sister or your neighbor or your cousin, because they do, even though they work the same way in everybody's body, they affect us in different ways, whether they are lowering the blood pressure in somebody maybe more than some others. So I just want to keep that in mind, that sometimes people say, oh, I was on that drug, but it didn't work for me. Or my mom takes that one and I tried hers, but it didn't have the same effect. So we caution people not to use other people's same medication because it may affect you a little bit differently. So these are the older medications, and we're going to start out by talking about some real common medications that have been on the market for a long time. And then we're going to jump into these two newer medications that the advertisements on the commercials are out that we see. One is called Jardiance. And this is a medication that really the advertisement or the commercials that we see are for diabetic patients. But happenstance in their research, they found that in half the dosage that we prescribe for diabetic patients, it's a really fantastic drug for people with heart failure. So we, over the last probably 3 to 5 years, have been using this drug exclusively for people with reduced heart function and have been having very good results. And then the newest drug on the market, probably in the last couple years, is called Entresto. And we'll talk a little bit about that. And that's one of the last drugs that we're going to talk about. And both of these are very expensive drugs, and but having very, very good results with people with very poor heart function. So we're going to talk about those at the end. All right, so let's start out in talking about oral anticoagulants. So the first drug that I want to talk about is warfarin. Now, this is an old drug. Many of you have probably been on it if you've either had atrial fibrillation, or maybe you've had a stroke, or maybe you even have a mechanical valve in. And the reason that we use these drugs, and I put this picture up because a lot of people are most familiar with what's called atrial fibrillation. And again, I'm going to go back to our prior talk. We talked about where this SA node, this is the natural pacemaker. And this kicks off the electrical signal that communicates the top part of the heart to the bottom part of the heart. But that signal kind of quivers up here, and it gets kind of confused and doesn't know what to do. And that quivering up here in the top part of the heart causes blood to pool. And over here in this pooling point where you see the blood pools, this little appendage over here in that left atrium, that's where blood tends to pool. And the faster that quivers, that blood clot tends to sit in there. And if that blood clot breaks off, that will travel to any artery. And oftentimes that goes up into the carotid arteries, which leads up into the brain. So people have a really high risk of having a stroke when you have atrial fibrillation. And if we go back into that definition of MACE, or that major adverse cardiovascular events that we were talking about, one of the main things that we're trying to do with prescribing oral anticoagulants like warfarin, the older drug, is to reduce the event of non-fatal strokes. So warfarin is a vitamin K antagonist, and warfarin prevents the liver from creating certain clotting factors by blocking vitamin K. So that's the main kind of purpose, or the main the route that warfarin works by. Now, the problem with warfarin is that you have to have blood work drawn. So when we ramp you up on warfarin, it's every 2 to 3 days. You have to have what's called an INR, and that can be kind of cumbersome for people. However, the great thing about it is now you can do that in your home. So it's not that you have to run to the clinic every 2 or 3 days. But once you're regulated on it, then it's once a month. The great thing about it is it's really cheap. It's a very cheap drug. So it's, I don't know, it's maybe $10 or $15 up to $30 per month. So it's a great drug. But the newer drugs that are out, like apixaban or rivaroxaban, which is Eliquis or Xarelto, they work on a little different clotting pathway. They do the same thing, but they've actually had proven to be better at preventing strokes for people with atrial fibrillation. So these are called DOACs, and they're the newer drugs, but they're very expensive. So some people, even up to $200 or $300 a month for these drugs. So some people can't afford them. So we still use warfarin, but again, the direct oral anticoagulants are the drug of choice for atrial fibrillation. So a couple takeaways, and for each drug, I'm going to give you a few takeaways in what we do for coaching and counseling when we have patients on these drugs. The first, again, because we're thinning your blood, these drugs are anticoagulants. They're antiplatelets. They work on the platelet or the clotting factors, so they make your blood less sticky or thinner. We really want to watch for signs of bleeding. The biggest one I would probably say that we see are nosebleeds. If you can't get the nosebleed to stop, we often see patients in the ER where we either have to cauterize that nosebleed or pack that nosebleed. And then we have to come up with a different plan on how we're either going to send you to ENT to try to fix that, or come up with some other plan for anticoagulation. We see a lot of bruising, and I know that's mostly what the biggest complaint is. We see a lot of black and blue arms, a lot of black and blue legs, blood in the urine or stool, and all of those are something that you need to report immediately to your provider. Food and drug interactions, the big one with warfarin is vitamin K is found in dark green leafy vegetables. So when you start on warfarin, we say don't eat a lot of dark green leafy vegetables. Now that doesn't mean don't ever eat broccoli or don't ever eat spinach. We try to work with you to say, are you a big dark green leafy vegetable eater? Because we can adjust your Coumadin levels based on, or your warfarin levels based on how much of that food you eat. But we kind of work with your diet so that we kind of level that out a little bit, because it's very hard to regulate that drug for people who eat a lot of that food. So we try to work with your diet. And the key consistency on this particular type of drug is that you take it the same time every day. That's pretty consistently within an hour or two, and that you never double up on them. So if you miss a dose, the key about these drugs is not to double up on it, but to skip the dose and then take it the next day at the same time, but then to inform your provider that you missed a dose and to consult with them to see if we need to catch up on a dose or how they want to do that. So those are the key takeaways on the oral anticoagulants. All right, the next one are the beta blockers. I think we use these for all kinds of things in the cardiovascular world. So one of the more common ones and a very old drug is called the beta blockers. And these are the drugs that end in the OLOL, and we'll talk about some of the more common ones, and the calcium channel blockers. So how do the beta blockers work? One of the cardiologists that I've worked with said the beta blockers are like taking away someone's caffeine in the morning. So beta blockers work on adrenaline. So they block the hormone adrenaline. So it's like taking away caffeine. So it's that fight or flight hormone. So if we take away that fight or flight, or we block that hormone, what are we going to do? If you're in fight or flight, your heart rate is racing and your blood pressure is high and your heart's pumping really fast. And again, for Halloween, remember, you're scaring somebody, so they're going to be in fight or flight. If you're on a beta blocker, we're going to reduce your heart rate, we're going to reduce your blood pressure, and we're going to relax that heart rate. We're going to relax that force of contraction. So what does it do? It just relaxes everything. So if you have hypertension and you are increasing your oxygen demand because you have hypertension, we are going to take all of that away with the beta blockers. So we're relaxing everything. We're blocking that hormone. So we use this for a lot of different reasons. People with high blood pressure, people with heart failure, angina or chest pain, arrhythmias, irregular heartbeats. And we also use it in the primary care and even the mental health arena for people with anxiety disorders. So it's a very kind of universal drugs for a lot of different cardiovascular reasons, but we also use it in some other areas of medicine, which is, so it's a great drug. The second part of the blockers that we use are calcium channel blockers. This is also a very old drug, and this works on contraction and relaxation, but more on the skeletal muscle and the cardiac muscle level, a little bit on the smooth muscle level in the gut area. So if you think about calcium, most of the time people's brain thinks about calcium in the bones. So calcium, when we're talking about cardiovascular, this is not the calcium in the bones. This is a cation, and it's responsible for muscle contraction. So it's not the same of calcium in the blood. So it works on the way that calcium moves in and out of the cells. So it results in vasodilation, results in relaxation of the vessel walls because we're blocking that calcium. So it lowers blood pressure, reduces the force of contraction. So if you think about a big muscle, when we're contracting that muscle, we're going to block that contraction. So we're going to relax that muscle and we're going to slow down the heart rate. And again, reducing that oxygen demand so the heart can just take a little breather and kind of relax a little bit so it's not working so hard. So these are a great category of drugs when we're just trying to relax the muscles and the arteries. Couple takeaways on these drugs, on the beta blockers, specifically the beta blockers. These are the OLOLs, the metoprolols, carvedilol. This is an old drug, the bisoprolol. That's a long one. Toprolol. That's another one. The big thing about this is when we're slowing the heart rate, if we take away your caffeine, we're blocking that adrenaline, you're going to feel tired when we first start you on this. If you think about the beta blockers, the lowest dose of metoprolol is 25 milligrams. We usually start people at 12.5 milligrams. The maximum dose of this drug is 200 milligrams. So if you feel tired at 12.5 milligrams, it takes about a week or two to kind of get used to it. And hopefully you'll start to acclimate to that. But we're also lowering your heart rate. So every time you come in, because your blood pressure is high, we're going to try to get you, again, remember, less than 130 over 80, but at the same time, we're lowering your heart rate. So you're not going to feel the best for those first couple weeks. We're monitoring your blood pressure and your heart rate. So we don't want to stop this drug suddenly, because think about that. All of a sudden you had all this adrenaline, and now we're up to 100 milligram, we're up to 50 milligrams, 100 milligrams, and your heart rate's slowing down and your blood pressure is coming down. And now all of a sudden you're on vacation and you ran out of your beta blocker. That's not going to be a good thing, because now all of a sudden you're going to have a surge of that adrenaline, and your heart rate's going to jump up, and your blood pressure is going to jump up, and you're going to be tachycardic again. You're going to have a very fast heart rate, and your blood pressure is going to skyrocket, and you're going to not feel so great. So you got to really make sure when you're on the beta blockers that you always have enough in reserve, or if you forgot them, to get to a pharmacy so that you don't run out of the beta blockers, because you will have significant side effects if you stop this drug abruptly. Again, the other thing that we also encourage for people when we're starting beta blockers and we're doing the titrating, we make sure that everybody has a home monitor, because we don't want your heart rate to get below 50. We took away your caffeine. We're going to drop your blood pressure and your heart rate. Heart rate's below 50, people don't feel so good. That means we have to back off on that drug and maybe try a different drug. So we do very close blood pressure and heart rate monitoring on the beta blockers. So those are kind of the three main takeaways on the beta blockers. On the calcium channel blockers, remember, we're slowing down that big contraction. And these are some examples, amlodipine, diltiazem, and verapamil. These are examples of calcium channel blockers. Unfortunately, with the calcium channel blockers, just the way the calcium moves in and out of the cells, swelling is very common. So we see leg and ankle swelling at even some moderate doses, especially with amlodipine. You can see some facial swelling with some amlodipine. It's a very frequent side effect. So you want to let your provider know. Mean that we don't use that drug at all, or we use a lower dose of that drug and add another drug. And it can cause some dizziness. So we want to make sure that you rise really slowly when you're moving positions. And also with the calcium channel blockers, usually with the diltiazem and verapamil, we try to avoid grapefruit juice or grapefruit, because it can interfere with the drug metabolism with the calcium channel blockers. All right, then we're going to move on to the ACEs and ARBs. So these two drugs are, they're probably in maybe the last 7 or 8, maybe 10 years. They work on a very complex system between your liver, your kidneys, and your lungs. They work on what's called the renin-angiotensin-aldosterone system. And I'm going to simplify this as simple as I can, but both sets of drugs work on doing these 4 things. They relax the blood vessels. They lower blood pressure by blocking aldosterone, which is a hormone that's produced from the adrenal glands, which sits on top of the kidneys, and that regulates salt in water. They're very protective of the kidneys, especially the ACE inhibitors. So we like to use those first. And both of them reduce the workload of the heart. So again, we're talking about relaxation of everything. When your heart's working too hard and those arteries are working too hard, we try to relax them. A lot of these drugs do that by blocking the hormones. So ACEs have been shown superior for all-cause mortality over ARBs, so that's why we start with them, particularly in heart attacks and in heart failure with diabetic patients. So how does this renin and angiotensin-aldosterone system work? So really what happens is we start out with, excuse me for a minute, I'm just going to take a little drink of water here. Thank you. So what happens is the liver, it all starts out really with the kidney. The kidney will feel something, it senses a drop in the blood pressure. And then all of a sudden the liver kicks in and it produces this enzyme called angiotensin. And they all rush in and they say, oh my gosh, something is happening in my body. It's too high or it's too low. Renin then is coming in. And I know there are much smarter people in the audience here. And Renin is converting angiotensin into angiotensin 1. The lungs then are producing what's called ACE, or this hormone that is then converting angiotensin 1 into angiotensin 2, which is raising the blood pressure. These ACE inhibitors are blocking this enzyme that is being produced from the lungs so that the blood pressures will come down, because they're inhibiting. These ACE inhibitors are blocking this enzyme that is being produced from the lungs, and that's how it's reducing the blood pressure and relaxing the I guess the vasculature, so to say. So that's how the ACE inhibitors are working. Again, very simply, but it works on all of the hormones being produced and the enzymes producing from the liver and the kidneys and the lungs. So it's a very complex system, but what we have found is they're very protective of the kidneys, and at different levels, they're blocking the hormones and the enzymes that work on the livers and the kidneys and the lungs. A major side effect of the ACE inhibitor is a cough, because you can see that this enzyme is being produced here, and we're blocking that enzyme with the ACE inhibitor. All right, 3 takeaways from the ACE inhibitors. Lisinopril and ramipril are the ACE inhibitors. They end in the prils. And the ARBs are losartan. They end in the TANs, or in the sartan, SARTAN. 3 top takeaways. With these drugs, we have to monitor potassium and the kidney function. So we need routine blood tests. Usually we start you on them for a week or 10 days. And then we check your kidneys and your potassium level to make sure that you're excreting the potassium and that you're not retaining the potassium. So we check those kidney function studies, kidney and potassium, at a week. And some people do get a dry cough from the ACE inhibitors. So then we substitute the ARBs for the ACE inhibitors. And the most important thing about both of these drugs is we need you to stay hydrated because of the kidney function and low blood pressure. So especially in hot weather or with illness, be mindful. If you are also on diuretics, we'd be very mindful of your fluid restriction. So we do a lot of reminding of your fluid restriction, as well as blood pressure, laboratory monitoring with these drugs in particular. All right, then the last 2 we want to talk about are the Jardiance, which is a new drug. This is a protein responsible for reabsorbing glucose in the kidneys. So this was a drug that I was talking about that they did initially the research with diabetic patients. And for diabetics, it blocks the reabsorption of glucose, so it lowers blood glucose levels. But for cardiac patients at half the dose, it's really producing a diuretic effect or pulling off water. So it encourages the excretion of excess sodium or salt from the body, which reduces fluid retention and eases the workload of the heart. It also does a little bit of cardiac remodeling, or improves energy utilization by the cardiac cells, again, working on sodium and calcium balance. And pegliflozin, which is the other name, that's the other name for Jardiance, and it helps restore what we call mitochondrial function, or cardiac cells in the muscle. And it also has reported some cardiac cell death protection, but that research is continuing. The problem with this drug for patients is, for 3 months supply, it can cost about $400 or $500. So we typically reserve prescribing this for people who have very low heart function, because for what it has shown in 10-year survival rates is the 10-year mortality rate is significantly lower for people than if they don't use it. So we have been able to find this drug significantly lower for about $1 a day, working with pharmacies in Canada. But here in our country, most insurance companies are not covering it very well. So if you're currently on Jardiance or your provider has said you should start this drug for cardiovascular reasons, it will not be covered if you're not diabetic, but the Canadian pharmacies are much more affordable for this drug if you're in need of it for cardiovascular reasons. And then the top takeaways for the SGLT2s is it does cause increased urination. So stay close to a bathroom. Take it in the morning you'll urinate for about 6 hours. Need to stay hydrated. And if you become dizzy or lightheaded when you stand up, you'll want to let your healthcare provider know because you want to stay hydrated. For women, because you're urinating more, we want to practice really good hygiene and stay dry. So we want to avoid yeast infections. And even in non-diabetics, it does reduce the risk of heart failure and hospitalizations for people, again, with cardiovascular disease. So it's been proven to be a very good drug in the repertoire of prescribed medications for people with cardiovascular disease. And then the last drug that I want to talk about is Entresto, and this is called sacubitril/valsartan, and it's a combination drug of the valsartan. If you remember, those are the ARBs that we just talked about, and the sacubitril. So it's a combination drug, and it really is meant to reduce the workload of the heart. So for people who have very poor heart function, for example, people who have had a significant heart attack, and let's say they only have about 40% of their heart that really is working strong enough to pump that blood flow out. I don't remember if we talked about this or not, but when we look at ejection fraction on an echocardiogram, it's not on a scale of 0 to 100. We say that left ventricle, if that's working at 50 to 70%, that's on the high end of normal. That's a normal ejection fraction. 41 to 49% is in that middle category. And anything below 40%, say 20 to 40%, is very, very poor. That means that the mortality rate of those people is very high over the next 10 years. So between lifestyle management and about 4 or 5 categories of these medications that we've talked about, the recommendations are a combination of 5 different categories of these medications. These last 2 being 2 of those. This is one of them that has found to improve that ejection fraction the most over a 3-month period of time. And it's really working on hormones, fluid and retention. It's working on that angiotensin receptor, the RAS process that we talked about, but it primarily works on reducing the workload of the heart, improving blood flow, fluid retention, and has a lot of protective cardiac cell and muscle properties to it. So this is the drug of choice. If we had to choose all of the drugs, it'd be beta blockers, and this drug, particularly for people who have significant heart failure or heart function reduction. Again, very, very expensive, can be up to $600 or $700 for 3 months. And we do a lot of work with the insurance companies to make a case for, prior auth for this particular drug. And I would have to say probably over the last 3 to 6 months, we're seeing more insurance companies meeting the criteria for heart failure with reduced ejection fraction, that they are covering this drug more and more as we're seeing better outcomes and survival rates for people with low heart function. So this has been a game changer in the world of heart failure. 3 takeaways on the ARNIs. You cannot combine this with an ACE inhibitor. So a newer drug, we have to stop the ACE inhibitors for 36 hours because you can have sudden cardiac death from that. We want to really watch your kidney function and potassium. So we do a lot of blood work and monitoring with this drug as we start ramping this up. And the other thing that we find with this is it does reduce blood pressure significantly on some people. So that home monitoring becomes a really important part as we talk about shared decision making. We do a lot of phone calling just about every other day or every 2 or 3 days when we start people on this drug, just to make sure that you're doing okay and your blood pressure is hanging in there with this drug. We usually start this drug as part of the heart failure regime in that 4 or 5 categories of drugs. And then in 3 months, we do an echocardiogram and see where you're at. And most often we see people move from that lower functioning, that less than 40%, up into that middle range of 41 to 50% within about 3 months. Typically, we see people recover from heart failure pretty quickly after starting this particular drug, as well as lifestyle modification, cardiac rehab, and the other things that go along with that. So this has been a game changer in the world of cardiovascular care. All right. And then I apologize. One last drug that you guys are seeing on the market now is called Repatha. This is a cholesterol lowering medication. And this one is an injectable drug. We've started to see this on the market because of people who are resistant to the oral agents because of the myalgias that are out there. So all of you that have been on rosuvastatin, Crestor, Lipitor, Simvastatin, that have the muscle aches and the body aches and you can't tolerate them. If you remember, we've talked about that your LDL needs to be below 100 if you do not have coronary artery disease. But if you have coronary artery disease, your low density lipoprotein now needs to be less than 55. A lot of people are not able to get to achieve that level because they cannot tolerate the oral statins. So the pharmaceutical companies came out with what's called a protein, PCSK9 is what we call them. And it's called Repatha. And what we have found is that it has been able to cut your LDL in half within about 3 months. So people who either have had an acute coronary event and their LDL is not at 55, or they are not tolerant of statins and they have coronary artery disease, you will qualify for Repatha. It's an injection every 14 days. And we've seen significant reduction in LDL below 55 and coverage for this through the insurance companies. Not going to tell you the prior auth is not a battle, but we will go to the mat. And these are what's recommended for, this is the newest drug out there, Repatha, and has shown, again, this has been a game changer for people who have coronary artery disease. And it has lowered the, improved the 10 to 15-year survival rate for people with acute coronary syndrome significantly over the last 5 to 10 years that they've done the research. So this is the newest one that you've seen out there called Repatha. Takeaways: muscle pains. With all of the statins, report any muscle pain or weakness. We need to do liver monitoring. That needs to be annually. And again, lifestyle still matters. Statins work, but we still have to do regular exercise, avoid tobacco, and they don't replace lifestyle changes. We're always gonna preach lifestyle modification before drug interaction or drug taking a new pill.